Hello everyone, you're welcome back to Island Academy, your ultimate resource for optometry success. In today's video, we'll be looking at binocular balancing techniques. But what is binocular balancing without appropriate subjective refraction? So I'll brief you a little bit about subjective refraction before we go ahead to talk about binocular balancing. So you would agree with me that for your subjective refraction, you'd ought to have started with your objective refraction. And there are two techniques for objective refraction, and those are retinoscopy and autorefraction. And I believe you already have an idea of how to perform those tests. So this video is not about objective refraction, but about a little bit about subjective refraction and binocular balancing. So let's assume you have already conducted your retinoscopy or your autorefraction. You first start with the prescription you have gotten from the objective refraction. You insert it into your patient's trial frame or you dial it into the phoropter. When you have done that, you go ahead to take your patient's visual acuity. That is your starting point. After that, you determine your patient's best vision sphere. We have a few methods of determining the best vision sphere. Number one is the maximum plus maximum visual acuity method. Number two is the best vision sphere method, or what we call the plus and minus method. So let's go ahead to have a little bit of demonstration of how to perform these techniques before we go ahead to do our binocular balancing. Before you place the phoropter on your patient's face, do well to clean the surfaces that will come in contact with your patient's face. And like I always say, do this in the presence of your patient. So I'm using the hygiene spray. There are different hygiene sprays out there that you can use to sterilize. So even if you're using the trial frame, make sure you sterilize as well. We have the objective refraction results in place. So for me to get the best vision sphere for this patient, I have occluded the patient's left eye and I'm working on the right eye right now. And then over the prescription in place, the spherical prescription in place, I'm going to add +1 diopter on each eye. So here I have +150 and I'm going to dial in additional +1 diopter. So I have +250 diopters right now. And then the essence of this is to blur the patient 4 lines worse than her best visual acuity with the prescription. How would I know her visual acuity with the prescription? When I put the objective refraction results, I made her to read the visual acuity chart. So when a patient reads the visual acuity chart, you determine your patient's visual acuity with that power. So you already know how to estimate your fogging, okay? So when I have blurred my patient 4 lines worse than her visual acuity with the objective refraction in place, I reduce the plus powers and I ask my patient for feedbacks. Remember that when you're changing the lenses, you give your patient a little time to respond. And for older patients, you need to be more patient with them because the older one gets, the less the person's ability to process things. Before you put the lenses in the trial frames, ensure you clean it very well because you wouldn't want the lenses to be smudged. That would reduce your patient's visual acuity and that can lead to errors. This technique is easier than the maximum plus maximum visual acuity when using a trial frame because less lens changes are typically required here. However, it doesn't provide a good control of accommodation in young patients as the MPMVA technique. As a result, you can use the +1 blot check or the duochrome, especially in pre-presbyopic patients, just to confirm your prescription. Start by occluding the left eye and directing the patient's attention to their best VA line. You are to use a plus 0.25 diopter sphere lens for the right eye you are working on, but when your patient's VA is relatively poor, you use a plus 0.50 diopter sphere, and then you ask the patient, are the lenses clearer with this lens? You place the lens in front of the patient's eye and then you remove it. Your patient will tell you when she sees better. If plus 0.25 improves your patient's VA, you keep increasing in plus 0.25 diopter steps until your patient says he or she has noticed a blur. Or if when you put the plus 0.25 diopter sphere the first time the patient says this is blurry, you take it out and then you put minus 0.25 diopter sphere and then you ask the patient which is clearer. If your patient says neither the plus or minus is clearer, you just do a confirmatory test of your sphere by using the Drochrome test prior to doing your GCC. And like I said earlier, you can always confirm by using the +1 diopter sphere blood test. When you're done with the right eye, you move over to the left eye and you do the same thing. And this is very important. Regularly change the letters on your chart so that your patient doesn't memorize the letters, especially if you have a computerized VA chart. Quick tip: when exchanging plus lenses in a trial frame in a young kyparo, do not remove the plus lens until the new lens has been inserted, otherwise your patient's accommodation can be stimulated. So after getting your patient's best vision sphere, the next thing you want to do is to go ahead to refine your patient's cylinder axis and power using your Jackson cross cylinder. I have already made a video on that. So if you want to learn more about how to perform the GCC, of which you should know how to, you ought to go and watch that video that I posted. Okay, so after watching that, you can come back to this video. Let's continue. So having done that, the next is for us to do our binocular balancing. But there's a caveat: you don't perform binocular balancing for all your patients. If your patient is amblyopic, if your patient is strabismic, if your patient is suppressing one eye, or your patient does not have binocular vision existing, there will be no need for binocular balancing. Also, if your patient's visual acuities on both eyes vary greatly, there will be no need for binocular balancing. So we have some methods of the binocular balancing technique. We have the fogging method, we have the alternate occlusion method, and we have the Prism dissociation method. Also, I'd like to remind you that binocular balancing is all about balancing accommodation between the two eyes. So, if your patient is a pseudophakic, there will be no need to go through binocular balancing. If your patient is an older patient, like from the age of 60 and above, this patient does not have any more accommodation left, so there will be no need for binocular balancing on this patient. If your patient just has monocular vision, of course you will agree with me that there is no need for binocular balancing. Start by placing plus 0.75 diopter sphere before each of the eyes before you introduce the Risley prisms. That is 3 prism bays up before the right eye and 3 prism bays down before the left eye. Your target will be an isolated line of letters, maybe the 612 or the 69 lines. So the patient will be seeing 2 targets, one above and one below. Ask your patient which of the targets appear clearer. Then you have to add plus 0.25 diopter sphere to the eye that is clearer. This is to blur it further. The end point is reached when either both sets of letters look the same or when the dominant eye appears slightly clearer than the non-dominant eye. Once the binocular balance is completed, add minus 0.25 diopter sphere OU one step at a time. This is to bring the patient back to their best visual acuity. For the monocular fogging method, I have fogged my patient's left eye until her VA has been reduced to 3 or 4 lines less than the tested eye. That is how it's done. So typically plus 0.75 or plus 1 diopter sphere should do this. When you have fogged the left eye, then you repeat the best vision sphere assessment for the right eye. When you're done, remove the fog from the left eye and fog the right eye. Repeat the best vision sphere technique for the left eye. And finally, remove the fogging lens and measure your patient's binocular visual acuity. So that brings us to the end of this particular video, and I just ran through the subjective refraction concepts briefly. So in subsequent videos, I'm going to make a more detailed video on subjective refraction. I hope you found this video helpful. Do give it a like if you found it helpful. Subscribe if you haven't yet subscribed, and share this video with your friends and colleagues. If you have any question, don't forget to drop that in the comments section.